Okay. Jill, are we starting?
We are. I will just like to welcome everyone to the ISQOLS Special Interest Group Mental Health and Psychological Wellbeing virtual webinar. And I will be happy to introduce one of our chairs, Lee Greenblatt Kimron, who will now introduce our speaker. Lee?
Jill, thank you so much. Good morning, good afternoon, good evening, everybody. I'm not sure how to start. As Jill said, we all over the world, so wherever you are. It is an absolute pleasure and a privilege to welcome you to the first virtual webinar of our special interest group, which we've opened, of mental health and psychological well-being. Yuval Palgi, Yuval, say hello. We're the chairs of the new special interest group. We're honored to have you join us for what we hope will be the first of many engaging webinars, academic discussions, and collaborations, activities, and lots of other plans in the months and years ahead. The goal of our group is to create a vibrant community where colleagues can share knowledge, exchange ideas, and advance scholarship in this important field. We are very excited to bring this journey together with you today. Before we start, we would like to express our sincere gratitude to Jill Johnson for her invaluable support, guidance, and assistance in making the SIG group and webinar possible. Jill, your dedication, your hard work, and your support have been instrumental in bringing this event together, and we are deeply appreciative of all your efforts. It's now my great pleasure to introduce our speaker for today, Professor Yael. Yael, say hello.
Hi.
Professor Yael is an associate professor at Tel Aviv University and a trauma researcher specializing in complex trauma, dissociation, and interpersonal victimization. Her work focuses on the psychological processes that shape trauma survivors' perceptions of themselves, of others, and abusive experiences, as well as the implications of these processes for psychopathology and post-traumatic adaptation. Professor Yael is known for her work on identification with the aggressor, including the development of the identification with the aggressor scale, which has contributed to the empirical study of internalized abusive dynamics and their consequences. Her research has demonstrated associations between identification with the aggressor and a range of outcomes, including re-victimization, PTSD, and complex PTSD. She has also developed the doubt regarding abuse-related appraisals framework and the abuse doubt scale, which examines survivors' difficulties in forming confident appraisals of abusive experiences. The broader program of research explores dissociation-informed perspectives on trauma adaptation, including the multifaceted nature of post-traumatic growth and its implications for psychological functioning, a line of research reflected in her presentation today. Professor Yael has published over 70 peer-reviewed articles and is the author of a book on trauma treatment. Her work integrates trauma theory, dissociation research, and clinical science to advance understanding of adaptation, well-being, and quality of life among survivors of interpersonal violence. Once again, thank you all for joining us today and for your interest in the work of our special interest group. We look forward to your continued participation in future webinars and academic activities. Yael, I'll now hand it over to you, who you will guide us through the remainder of the session with your insightful and stimulating presentation entitled Two Pathways to Post-Traumatic Growth, a Dissociation-Informed Model with Evidence from Female Survivors of Childhood Sexual Abuse. Enjoy the session.
Thank you so much, Lee, for the warm introduction and for having me here. It is a great honor to be here today, and I would like to begin by thanking Professor Yuval Palgi and Dr. Lee Greenblatt-Kimron, the leaders of the Special Interest Group on Mental Health and Psychological Wellbeing, for their invitation. I would also like to thank Jill Johnson, Executive Director of the International Society of Quality of Life Studies, for coordinating this webinar. Thank you. So this map comes from a large international study conducted by Kessler and colleagues across 24 countries. More than 70% of participants report being exposed to at least one traumatic event during their lifetime. In other words, trauma is not the exception. It is a common human experience. People encounter trauma in many different forms, including violence, disasters, accidents, war, and serious illness. From a mental health perspective, we know that trauma exposure is strongly associated with psychological distress and psychopathology, and it also may hamper people's well-being and quality of life. At the same time, we know that responses to trauma vary considerably across individuals. While some individuals suffer from elevated distress, others may show resilience and, in some cases, even positive changes. Traditionally, trauma research focused mainly on a pathology-oriented approach, studying conditions such as PTSD, depression, and anxiety. However, since the 1990s, there has been a clear shift in focus. The field has expanded toward a salutogenic approach, emphasizing factors that may support resilience, adaptation, and well-being. From a quality of life perspective, this shift is very important. It allows us to move beyond symptom reduction and to consider how people maintain or rebuild the sense of meaning and life satisfaction after trauma. Within this framework, we now study concepts such as benefit finding and post-traumatic growth, or PTG, concepts that help us understand not only recovery from trauma, but also how people can grow through adversity. Post-traumatic growth, or PTG, is a term used to describe perceived positive changes following trauma. This concept was first described by Dissociation-Informed Model in 1996, and later work further developed this concept. In this framework, three main domains are typically described: positive self-perception, which include stronger sense of personal strength, as well as an increased ability to discover new possibilities in one's life; enhanced relationships, which include closer, more intimate, more meaningful relationships with others, as well as an increased sense of compassion; and also change in life philosophy, which includes a greater appreciation of life and also a possibly positive religious or spiritual change. It is very important to note that PTG mainly refers to perceived positive changes, and it is often measured via self-report questionnaires. Dissociation-Informed proposed a theoretical model explaining how PTG develops following trauma and how growth may exist side by side alongside the post-traumatic distress. According to this model, growth is not an immediate outcome of trauma, but rather the result of cognitive and psychological process that unfolds over time. Specifically, the Dissociation-Informed refers to three main phases. In the first phase, trauma survivors experience significant distress. The trauma shatters their prior beliefs regarding themselves, others, and the world, and during this phase, reports of PTG tend to be low. In the second phase, active meaning-making becomes central. Trauma survivors ruminate and build their sense of self and their goals, and this process can happen alongside anxiety or PTSD symptoms. Lastly, in the final phase, schema reconstruction takes place so that real integration begins. Trauma survivors develop a more complex, integrated belief system, one that incorporates their traumatic experiences into a broader understanding of themselves and their world. At this stage, they may report higher levels of PTG, even while holding persistent trauma-related cognitions. This slide summarizes research on PTG across trauma types. PTG has been documented following a wide range of traumatic events such as medical illness, accident, interpersonal assaults, collective trauma, and also sexual violence, including childhood sexual abuse, which is the focus of the studies that I'm going to present to you today. Taken together, these findings suggest that PTG is a widespread phenomenon, not limited to any single trauma type or population. Tedeschi and Calhoun argue that individuals can experience growth and at the same time suffer from post-traumatic distress. But this raises an important question. Can someone who is living with severe symptoms truly experience growth? To help think about this, consider an analogy from medicine. Imagine a patient with a severe injury who continues to experience persistent symptoms, but at the same time reports some positive changes in the injured limb. We wouldn't automatically assume that real healing or true growth has occurred. In the same way, when we think about trauma survivors who report PTG alongside ongoing post-traumatic distress, we have to ask, does this reflect genuine psychological change, or is it more about coping strategy that helps manage the distress? Research examining the relationship between PTG and distress has produced quite inconsistent findings. And this suggests that the question we just discussed, whether reported growth reflects genuine positive transformation, remains unresolved. Some studies suggest that higher PTG is associated with lower distress over time. Others found no association between PTG and distress, and still others report the opposite pattern, with higher PTG associated with greater distress. And this last pattern appears in my own research. For example, in a longitudinal study among partners of trauma survivors, namely survivors of indirect exposure to trauma, we found that those who reported elevated levels of PTG at baseline suffered from more PTSD symptoms at follow-up. In another study that we conducted during the COVID-19 pandemic, we found that trauma survivors who reported elevated levels of PTG attributed to prior trauma suffered from more distress during the pandemic. So these inconsistent findings regarding the association between PTG and distress have sparked a theoretical debate regarding the nature and the meaning of PTG. On the one hand, Tedeschi and Calhoun argue that PTG reflects authentic positive transformation resulted from schema reconstruction. On the other hand, McFarland, Alvero, and others argue that reports of PTG may sometimes reflect wishful thinking that does not correspond to actual improvement. Bringing these views together, the genus-face model proposed by Marker and Zollner views PTG as having two parts: a genuine component linked to active struggle and adjustment, and an illusory component potentially related to avoidance. Although the genus-face model substantially contributed to our understanding of PTG, this model does not provide an answer to two very important questions. First, what determines which pathway a survivor follows? And second, if we assume that authentic PTG is embedded in an integrated belief system, what does the belief system underlying illusory PTG look like? So the theoretical model that we developed aims to address these questions. Building on the literature and drawing on my own clinical experience working with trauma survivors, I began to consider that PTG may not reflect a single uniform process. Instead, it may emerge through two different pathways with very different meanings and very different consequences. Within this framework, dissociation may be the key factor that determines which pathway we are looking at. Dissociation refers to a disruption in the integration of mental processes so that thoughts, memories, sensations, emotions, feelings may become partially disconnected from one another. And in the context of PTG, this disconnection may shape whether reported growth reflects real transformation or something quite different. The study I'm going to present aimed to explore this supposition among survivors of childhood sexual abuse. Childhood sexual abuse is a severe trauma and it is associated with multiple negative consequences. We also know that this type of trauma is a risk factor for a sexual re-victimization that is being subjected to an additional sexual violence at later life stage in life. At the same time, some survivors of childhood sexual abuse report PTG, which raises the following questions that we explored in our study. What is the relationship between PTG and sexual re-victimization among adult survivors of childhood sexual abuse? And does dissociation moderate this link? To address these questions, we conducted a study published in 2020 in Child Maltreatment. And this work was carried out in collaboration with Professor Karni Ginsburg from Tel Aviv University and Professor David Spiegel from Stanford University. And I would like to take a moment to thank them both. The present study was a secondary analysis of data driven from a randomized controlled trial of group psychotherapy for survivors of childhood sexual abuse. And this study included two assessments, baseline and 6-month follow-up. We focused on natural variation in PTG and dissociation, not the intervention itself. Participants in the study were female adult survivors of childhood sexual abuse. They also had HIV risk factors at baseline, namely elevated re-victimization, high-risk sexual behavior, and also substance abuse. 111 women completed the baseline assessment and 95 completed the follow-up assessment. Our analyses were conducted on the full sample using maximum likelihood estimation to account for missing data. No differences were found at baseline between treatment conditions except for PTG, and therefore we statistically control for intervention type in our main analysis. PTG and dissociation were assessed at baseline. PTG was measured using the post-traumatic growth inventory, and dissociation was measured using the multiscale dissociation inventory. Sexual re-victimization was assessed both at baseline and 6-month follow-up using the Sexual Experiences Survey. And we conducted analysis in order to explore whether PTG at baseline predicts later sexual re-victimization and whether dissociation moderates this link. So first, we conducted intercorrelations among study variables. As you can see in the first column, it is highlighted in blue. PTG at baseline was unrelated to re-victimization either at baseline or at follow-up. Dissociation, however, was correlated with attempted rape at baseline and rape at follow-up with medium effect sizes. It is highlighted in red. So based on these very basic correlations, it appeared that PTG was unrelated to sexual re-victimization. But what happens when we take into account dissociation? So in order to explore whether dissociation moderates the link between PTG at baseline and sexual re-victimization at follow-up, we conducted a step-by-step regression analysis. We first controlled for baseline re-victimization at baseline, and intervention type. Then we added dissociation at baseline and PTG at baseline, and finally, in the last step, the interaction between them. So as you can see, we found significant interactions between dissociation and PTG at baseline in explaining sexual coercion at follow-up and also rape at follow-up. In order to explore conditional effects, we used highest process macro, and we found a similar pattern. So as you can see in the slide, when dissociation was low, PTG at baseline was unrelated to sexual re-victimization at follow-up. However, when dissociation was high, PTG at baseline was related to both rape and sexual coercion at follow-up. The higher the PTG, the more sexual re-victimization at follow-up. So what do these findings mean? In order to understand these findings, let me take you back to the model we suggest. According to our model, PTG does not reflect a uniform single process, but rather two pathways. And dissociation is the key factor that determines which pathway we are looking at. Specifically, according to our model, when dissociation is low, trauma survivors can do the hard work of processing the trauma, and schema reconstruction can occur, leading to a more complex integrated belief system. The PTG that emerges is real, and it tends to be modest, not dramatic. It may resemble what Viktor Frankl described, meaning found within the pain. And this type of PTG, authentic type of PTG, carries no extra risk and may even support well-being over time. But when dissociation is elevated, something very different happens. Although dissociation enables survivors to avoid feeling the pain rooted in the trauma, it impedes their ability to process the trauma and may lead to the formation of a detached protective narrative of PTG, a narrative that is out of touch with the reality of the trauma. And although this narrative may bring some relief by attributing benefits to the painful experience, it may hamper recovery and intensify distress over time. So, according to our model, contrary to authentic PTG, which is embedded in an integrated, complex belief system, dissociation-driven PTG relies upon a disintegrated, fragmented belief system. And this system consist of two conflicting sets of cognitions that remain disconnected from one another. On the one hand, there may be negative beliefs regarding the self, others, and the world rooted in the trauma. And on the other hand, protective, detached beliefs of growth. And since these two sets of beliefs are not integrated, survivors may fluctuate between them. One moment, they may speak the language of growth, while at another moment, they may express pessimism and despair. And this movement appears to be abrupt, not gradual, as if we are listening to two different people. So based on our model, authentic PTG may be unrelated to distress and in some cases may be related to lower distress, while dissociative PTG may be related to elevated distress. But how exactly does this type of PTG, the dissociated type, translate into an increased risk of re-victimization? We offered two main explanations. The first is illusory invulnerability. According to these explanations, survivors with dissociation-driven PTG hold protective beliefs concerning personal strengths and overcoming the trauma. And since these beliefs do not rely on processing the trauma, they may create an illusory sense of invulnerability, which may lead to failure in detecting danger or taking precautions, and put them at risk for additional victimization. The second explanation involves distress and coping. According to this view, survivors with dissociative PTG suffer from distress that continues to build over time. And therefore, they may rely on strategies such as substance abuse or risky sexual behaviors, which create short-term relief, but increase the risk for re-victimization. Our findings also indicated that when dissociation was low, PTG did not predict later sexual re-victimization. It was unrelated to re-victimization. How can we explain these findings? So one possibility is that authentic PTG may be beneficial in some domains, but not in others. Authentic PTG may enhance feelings of hope among trauma survivors, but at the same time do little to reduce the risk of re-victimization. Another possibility is that authentic PTG is not a cure. It does not make surviving easy. Rather, it reflects a search for meaning within the pain. And that search, as real as it may not be powerful enough to counteract the pull of traumatic reenactment, especially in a sample carrying such a high cumulative burden. Like any study, our study has some limitations that should be noted. First, all measures were self-reported questionnaires, which introduces the possibility of response bias. So it is very important that future studies will incorporate clinical interviews and behavioral data. Second, we didn't directly assess potential mechanism within the relationship between dissociative PTG and re-victimization, such as risk evaluation and self-protective behaviors. So we recommend that future studies will explore these mechanisms in order to enhance our understanding regarding the potential relationship between PTG, specifically dissociative type of PTG, and re-victimization. Lastly, our sample was small and specific. These were women at elevated risk for HIV due to sexual re-victimization, high-risk sexual behavior, or substance abuse. And although this combination of vulnerabilities is very important clinically, it also means that we should be careful about generalizing. Prospective studies with larger, more diverse samples are highly needed. Although the current study suffers from limitations, it also has important theoretical and clinical implications. First, this study suggests that PTG may not be a single uniform phenomenon. There may be two types of PTG depending on the levels of dissociation. And while authentic PTG may be unrelated to distress, dissociative PTG may be maladaptive. In addition, our results and our model may help to explain the inconsistent findings concerning the relationship between PTG and post-traumatic distress found in previous research. Specifically, it might be that when authentic PTG predominated samples, then it was found to be unrelated to distress or to be related to lower distress. However, when dissociative PTG predominated the samples, then it was found to be related to elevated distress. The same measure may reflect different phenomena. Lastly, our findings point to the importance of distinguishing between these two types of PTG in psychotherapy. Clinicians should not deny reports of growth, but at the same time should not take reports of growth at face value. Instead, it is highly recommended that they explore reports of growth and try to understand what lies beneath them. And when needed, help survivors approach aspects of the trauma that they may have been trying to not to feel. Because genuine PTG does not necessarily come from avoiding the pain. It may emerge from working through it. I want to leave you with a thought from Viktor Frankl, because I think it captures what authentic PTG really feels. Frankl does not say that pain goes away. He does not say that trauma leads to growth. He says that suffering can transform when it finds meaning. And that meaning, as he understood it, comes at a price. It asks something of us, a willingness to go through the pain. This, I believe, is what authentic PTG feels like. Not an escape from the pain, but a willingness to go through it, to grieve, to integrate, and to emerge slowly with something real. What our findings suggest is that not all reported growth reflects this process. For some trauma survivors, reported growth is a shelter from the pain. And our task as researchers and clinicians is to understand which one we are looking at. Thank you.
Thank you, Yael. It was great, and make a lot of thought about your ideas. I found myself thinking about all the theories and how can we know if it's real growth or not real growth. Let us now move to questions. If someone from the audience want to ask a question, please open the camera and ask your questions.
Hello.
Hi,
Thank
hello.
you.
Hmm.
Yes, thank you. I'm Anthony from Malawi. Thank you for a very insightful research piece that you have shared with us. I just a minor, but I wanted to know. I know it maybe don't have clinical significance, but why did you, should I say, limit yourself to people, women, young women, or women who had experienced or they're into drug? Why did you particularly isolate that group that you used for your study? Did you had something that was, within your mind that drove you to do that? Thank you.
Thank you so much. Thanks for the important question. So we wanted to conduct a preliminary study in order to explore the suggested model. So it wasn't something that we thought about before we conducted the study. We didn't want specifically this type of sample, and it is one of the study's limitations. But I must say that since then, we conducted another study among survivors of psychological, physical, and sexual childhood abuse. And we found similar patterns. Specifically, we found that some survivors reveal this link between PTG and dissociation, and also identification with the aggressor. This is another topic. It's very complicated, but we know that it is a negative outcome of abuse. And this specific group also suffered from elevated distress. So we found a similar trend among a different sample. And also this specific sample was also bigger and more diverse. But I must say something. Of course, that we need more studies that will explore this relationship between PTG, dissociation, and various outcomes among trauma survivors. It is highly needed. The model is still developing, so more research is highly needed.
Anybody else?
Do we have any more questions? I think it was so intriguing that people are finding it hard to even find the words.
I see something in the chat, maybe? Am I
Yeah,
wrong?
that was for me. Thank you so much. I'm wondering if anyone else has a question, but I did have just a thought as it relates to our broader quality of life researcher audience. If post-traumatic growth can sometimes reflect, as you say, genuine healing, and other times it can reflect what you call dissociative coping
Dissociation.
processes. How can quality of life researchers tell the difference when they're studying well-being after trauma?
Wow, that's a great question. Thank you, Jill. I think that quality of life researchers could explore satisfaction from life and quality of life among the trauma survivors and its relations to PTG while taking into account dissociation. It might be very interesting to see whether dissociation moderates this relationship. And I think it's very important because if there is this type of dissociative PTG and this type might be maladaptive, it could hamper quality of life and satisfaction from life and well-being among trauma survivors. And this was the reason that I began studying this type of PTG.
Thank you.
Thank you.
May I ask something as well? Do you think, because dissociation is something that protect us from something, other cases where you see that dissociation that relate to post-traumatic growth is good or help people? At
Wow.
least theoretically, I don't know because
I think I must be cautious because, our findings are preliminary, but I think at the same time that this type of PTG bring some kind of relief, short-term relief. So
yeah, that was my thought. Yeah, that
yes,
it may help for short time, but if you
short
don't
time.
change it into authentic PTG, it will.
That's exactly what we argue. Yes, it is very recommended that when patients come and report of PTG, and we think that it might be a dissociative PTG, that we validate their experience on the one hand, but at the same time try to help them process the trauma in order to develop authentic PTG and to acknowledge the loss and the pain rooted in the trauma.
So you say that quality of life must go through pain.
I think that, yes, in order to find meaning within the pain, you have to acknowledge the pain, you have to grieve. But I think that it could help enhancing quality of life and life satisfaction. So it's in the short term, it might be painful to process the trauma. We know that nobody wants to experience the pain. Nobody wants to remember traumatic experiences. But over time, this authentic growth could be helpful and enhance one's well-being.
Yeah.
Yael, you're such an inspiration. Yeah, I've got so many thoughts of how it's possible to try and, I don't know, broaden the understanding which you're bringing to us. I think you're just bringing us the outline, but I think there's so much growth that can continue just from this lecture of 50 minutes, which has just been so inspiring. Thank you so much.
Well, thank you very much, Lee. I really appreciate it, and I'm so happy to hear that you find our model interesting, and thank you.
It's not only interesting, it's inspiring, Yael.
Thank you. Thank you so much.
Do we have any more
just to add, it's
please.
quite inspiring, really. It's quite inspiring. I just wanted to hear from you as in terms of comments. In my clinical practice, usually I see patients, not wanting to share their pain. And half the time they would say, I don't want to talk about that. They would like to skate around whatever actually the painful experience they've had. And yet we know from your presentation that it's better that they actually face that traumatic event. What would you advise, if you may, in terms of helping the client as quickly as possible? Because sometimes what I've seen in my practice is that they would open up later, in maybe after several sessions is when they would open up. But how soon should we, is it not coerce, but help the patients to open up as early as possible, so that now that we know that dissociation is not good for their own healing? Thank you.
Thank you so much for this question. I think it's very important question. I believe that we should give trauma survivors time in order to build trust and connection with us, first of all, because the processing of the traumatic experience is very intimidating. Okay, so we have to be patient. At the same time, I find dialectical approach very helpful. So on the one hand, validating their need to avoid talking about the trauma, their need to dissociate, validating their need, but at the same time, trying to encourage them to process the trauma, to talk about elements of the traumatic experience. And this is something that we can do gradually. It's not a process that we can make, that we can do in a short time, okay? We have to be patient and to provide our patients the feeling that we understand them, we understand their need to dissociate. And this is a challenging place to be in, because we want to help them to stop relying on dissociative processes. But if we understand that dissociative processes bring actual relief in the short run, then we can validate them. I think that from this type of validation, we can help them to move on, to process the trauma. And we can, of course, we can use interventions that have been found to be very effective, such as EMDR therapy or PE intervention. So integrating these interventions may be very helpful.
Thank you, Yael. I think that we are out of time now, right, Jill?
Sure.
Closing in on it, if anyone else has any other questions or comments, welcome to ask Yael. We are, as a reminder, we have a special page that's dedicated to this special interest group on our Slack channel. So if questions do come up after this session and you'd like to reach Yael, we'll be sending that out via email, as well as the recording of this session and posting that in the special interest group page as well. We encourage you, if you're not a member, to become a member, that you'll have access to joining this group. On behalf of ISQOLS, Yael, Dr. Lahav, thank you so much for this inspiring, as we said, presentation, and for your work, truly transformative in this space. So we look forward to future research and future presentations from you. Yuval and Lee, thank you so much for your guidance and leadership as the chairs for this special interest group. Thank you to all of our presenters and for those great questions. With that, we will end this session, and with
Jill,
another.
wait one sec. I need to say thank you to you. I need to, on behalf of Yuval and I, and of course Yael, but Yuval and I, who you've just helped us really get this going, and we appreciate it so much. So we can't end off without saying thank you to you.
My pleasure.
Thank you very much. Thank you for having me. It was a great honor. Thanks. Thank you, Jill and Lee, and of course, Yuval. And thank you.
Excellent. And much more to come, we hope. In the future, we'll have you back on, Yael, to give us a future research presentations as well. And if anyone is interested in contributing towards this special interest group, we invite your participation. Look forward to that email and the link after this. But with that, we'll say thank you and goodbye. Thank you for joining us.
Thank you. Thank you. Bye, 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 bye.
Bye, thanks.
Bye. Take care.